Good morning. Welcome everyone to the March Allen County Health Equity Coalition meeting. I'm so glad you guys could join us here in person and online. Excuse me. This morning, I have asked Miss Peggy to do the opening meditation, and so we will tune our screens to her, and she will take the floor.
Good morning, everyone. As I was
Good
sitting
morning.
here this morning thinking about meditation, today I invite you to rediscover forgotten treasures. And it says today, are not 5 sparrows sold for 2 pennies, yet not one of them is forgotten by God. A time to rediscover, time to think. The world is full of magic things, patiently waiting for our senses to grow sharper. There's a time to act. Thank God for the reminder that everything has a purpose, no matter how forgotten it may seem. And a time to pray. Dear Lord, teach me to approach each moment, each thing, and each person with gratitude for the purpose you've built into everything. And today's meditation is make God your center today as you focus on His word. Let His love for you seep into your heart and bring you the peace that only He can offer. This is our meditation for today, and I pray that you embrace the day and enjoy this sunny, beautiful day.
Right on, right on. Well, thank you so much, Ms. Peggy. Yes, no, it is definitely amazing just to have those pauses and to reflect, and just enjoy the day, as she stated. I think the sun is going to keep shining today, which I know we all look forward to. Even though yesterday we were in coats and the day before we were in shorts and then the day before that we were in coats, and it's just a whirlwind. But I think that's so amazing, and it speaks so much to us in the Midwest of just the everlasting change that we all go through each and every day, and we're able to just continue just to push forward. And so I want to introduce myself. I am Mr. Cassius Stallings. I serve as a community outreach coordinator with Health Visions Midwest of Fort Wayne. And I want to take a moment to kind of go around the room and introduce everyone else who is here today. And so we'll start to the right of me, the other right, with our new coworker.
Hi. So I am the newest member to the Health Visions Network team. My name is Jania, and I will be a certified community health worker. So I'm excited to be here, and yeah.
Welcome, welcome. This is Jania's first ACHEC meeting. And then we have another first timer.
I'm Melinda Scott. I work with Oak Street Health. My role is with community outreach. So this is my first meeting, but my associate group has attended in the past. I'm excited to be here and see what all of this does.
Welcome, welcome, welcome.
Good morning. Outreach and Education Coordinator for the Allen County.
Hi, good morning. I'm Diane Rogers with the Outreach Association.
Thank you for being here.
I'm Audrey Dominguez. I'm here with the Allen County Department of Health.
Good morning. I'm Lauren Richline. I'm the Director for Wellness and Education at Cancer Services.
I'm Danielle Furge. I'm the Education and Outreach Manager at ACHEC.
I'm Jackie Martinez with the St. Joe Community Health Foundation, the Community Impact Director.
Hello, Lupita Valdez, Television's bilingual community health worker.
I'm Carla Kilgore, Director of Mission Advancement at YWCA.
Sheila Curry Campbell, Pilgrim's Progress Community Development Court.
Welcome, welcome. Thank you all for that introduction in room. Now let's talk to you online. I see some folks, whoever wants to come off mute and say hello, introduce yourself.
I am Ivan Douglas Hicks. It's wonderful to be with you today from the AfricaLogical Institute.
Welcome, welcome, Dr. Hicks.
Hi, I'm Diane Starks. I'm with Urban Beginnings Choice Federal Credit Union, and I'm glad to be here today.
And Ms. Starks, this is your first time joining ACHEC?
That is correct.
Welcome, welcome. Thank you for being here.
Good morning. I'm Jared Blanchard from Purdue Extension.
Welcome there, welcome.
Good morning.
Good morning.
Go right ahead. You're prettier than I am.
Good morning. I'm Carla Harrison from the Indiana Department of Health.
Good morning. I'm Jeff Markley. I'm with the Northeast Indiana Positive Resource Connection.
Good morning. I'm Donna Masterson. I'm with the YWCA.
Good morning. This is Esther with United Healthcare. Glad to be here today.
Good morning. I'm Carlos, and I'm with Neighborhood Health.
I'm Chelsea Owen, and we're with Aging and In-Home Services.
Welcome, welcome.
Good morning. I'm Shelby. Go ahead.
Good morning, I'm Cassandra Rosine with Stillwater Hospice.
Good morning. I'm Shelby Van Bibber with Great Heights ABA.
Good morning. I'm Temecula Nelson from Bright Point.
Denise Knibler with IU School of Nursing here in Fort Wayne, Indiana.
Good morning, Kalila Hanan, Center for Nonviolence, Fort Wayne.
Good morning, Audrey Davis, laying the groundwork for a new initiative in Fort Wayne called the Truth, Racial Healing and Transformation Project.
Welcome, welcome. I believe that is
Joyce.
Oh, Joyce, go ahead. I'm sorry.
Good morning, Joyce Lothimer with United Healthcare.
Good morning, Colleen Carpenter with Stop Suicide Northeast Indiana.
Good morning, Diana Jackson Davis with Parkview Health.
Good morning, Sharon Tubbs, Executive Director of Health Visions Midwest.
Good morning, David Craig. I'm with IU Indianapolis.
Laurie Weinzapfel, also with United Healthcare.
All right. Now I think that was everyone online. If there's anyone I missed, please jump off mute and let us know. But with that, we are introduced. Everyone is welcome. We're so glad that you have joined us. Our presenters today will be online. And so our first person to speak is Dr. Diana Jackson, and she serves as a Director of Language and Culture Services at Parkview Health. And she will talk a little bit about the non-discrimination policies and role changes that have happened at Parkview Health and a few other topics. And so we now will give her the screen.
All right. Good morning again, everyone. Glad to be here. And thank you, Cassius, for inviting me. I'm just looking at two screens, so bear with me for a second. And I'm going to share my screen really quickly. Well, it was there, so let's see. Okay, so let's see if I can pull this again. Just give me a second. Apologize. I'm sorry, but I don't know what happened to my just work when we just checked this. So, all right, well, doesn't look like I'm going to be able to share my screen. I'm just going to have to talk you through it. Yeah, so my name is Diana Jackson Davis, and I am the Director of Language and Cultural Services. Many of you know me as the Director of Diversity and Inclusion for Parkview Health. But we had a few changes, and actually my change occurred right before the executive order went in. So I've basically been the Language and Cultural Services Director since 2023, and which allowed me to really focus on expand some of the things we still do with DE and I, but also really build a language department that we've not had before. So that is one of the big things that has happened. I just wanted to touch a little bit briefly on the 1557 non-discrimination policy. A lot of people, they don't really know what this is, or particularly immigrants, or even, just regular citizens. They don't know what the policy is or where to find it. And I thought it was important because recently there were some changes made at the federal level, which expanded the federal requirements for what we are required to do in terms of language services. And so the non-discrimination policy really is, it's the Affordable Cares Act that prohibits the discrimination of the basis of your national origin in healthcare. And it has a section 45 CFR 92. And one of that section in particular was actually updated. And just the number itself, one of the requirements that happened was we had to now have it on our signage. It wasn't on the signage prior, but that section has to be noted. One of the big things is one form of national origin discrimination for us is failure to provide meaningful access to individuals with limited English proficiency when required by law. And a lot of times people, they don't even know that this is a standard requirement that you should provide as a free service. So the expanded federal requirements includes now is patients with limited English and people who have disabilities. And that means we have to grant meaningful access to our programs and services and activities as related to the 1557, but also including the Affordable, not the Affordable Care Act, but the ADA requirements, now including people who have disabilities and people who are deaf, hard of hearing, or blind. And so, which has been interesting as I'm doing a lot of research in this area. So we already know with our immigrant community in Fort Wayne, at least in the past 20, I would say in the past 15 years now, because the last census was 2020, that the Fort Wayne Northeast, well, at least Northeast Indiana has increased from, I think it was we were about 7.2% of non-English speakers, and we jumped up from 2010 to 2020, we jumped up by 7.7%. Right now, currently we're at 13.8% as non-English speakers. And that means that about 9%, we're up 9% of foreign-born citizens up by 9%, with an increase of 3+%. So those numbers are really high, and I'm really seeing a lot of these changes, at Parkview, just based on the number of non-English speakers that are coming in for services. Another fact is when we often talk about, we don't really talk about disabilities or people living with disabilities, but in Northeast, about 10.5% of our population under the age of 65 have a disability. And people with visual impairment are about 3.4% of who actually identify themselves as visually impaired. About a little closer, 1% of blind, and about 2.9% have moderate to severe impairment. And so as my role has changed, and my focus has begun to look at the needs of language services, I've now had to include those with disabilities just to make sure, to assure that we are able to provide all of the services to families, patients, and family members as they come in. And so if a family member does come to Parkview Health and let's say they're a non-English speaker, or they are blind and or deaf, or hard of hearing, we will provide that service. We will have the notice, or not that we will have, the notices have been posted all around the hospital. So every hospital that you go to, if you look for the patient's rights policy, you will find the 1557 postage. One of the things about the 1557 is you have to have that posted in a visible area, whether it's in the entrance or at a walk facility, a clinic, or the doctor's, where, you know, if a patient needs that service, they can ask for that. And so we've updated, I started updating all of the signages last year because it went into effect November 1st. And so we have some other changes coming with 1557. One thing I can say that that has stood out to me is the requirement for organizations that have more than that have several interpreters. So if you have more than 15 employees, right, at your organization, you're also required to follow the 1557 guidelines. And so that's something that is important to know. And with that requirement, I also became the 1557 coordinator, and that was an actual appointed position. And so just making sure that, you know, the hospital, the health system in a whole is compliant with all of the updates. Now, with that being said, that doesn't mean that these things won't change. It's a possibility that some of the things may change with the new administration. And I think they will be looking at this sometime in April, so that we may have these changes. Things may change again, I should say that. So some specifically in the rule for the 1557, I'm just going to jump back to that. It just requires that health programs, activities, with the same non-discrimination standards as the recipients of federal financial aid. Basically, if you're receiving any federal funding, then you are required then to follow these laws. It also looks at the Medicaid B, and because they consider that a form of financial assistance. And so under the section 1557, that federal civil rights law and still is enforced. And so again, it just requires insurers and guarantees and others that allows them to get the language services. There's one other thing that they really focused on, because I attended several trainings, is the use of telehealth, which includes things like, you know, the use of AI. So they are looking at all of those things, and specifically look at the use of artificial intelligence and clinical algorithms, because you have to have policies that are designed to protect the use of language. So if you're using interpretation services and you're using AI, you do have to have a policy in place that actually highlights why you're using it, how it's used, so that you're in compliance, again, with the guidelines for the 1557. I will be offering a training on that. I'm still going through and creating what my training module will look like. And so once that's done, if you, for local agencies that may want it, just feel free to reach out to me and I can come to your agency and train you on that. So what has Parkview done? Well, we are publicizing the right to the availability of free services, meaning that they are posted. And also we're going to create cards. We want to make sure that patients know when they come in that the services are there for them. In 2023, we created the new department, which is my department now, for the health system. And we really undertook a huge implementation of updating our vendor use. And so we changed our language service provider and moved to a new vendor who is providing services virtually on the iPad or the desk phone or cell phone. So each hospital has their own designated number that they can call. If they can't get somebody on the iPad, they can use their regular phone to call in, and that number is assigned specifically to that location so that we can actually collect data, because now I can collect that information in real time, which not that we couldn't get the information, but it could take 2 months, 3 months to even get the information about data use. But now I can get it from years back to the night before, so yesterday, if I wanted to look at data. And I can identify the use for the whole system, or I can identify the use for specific locations. And we are continuing to assess the language needs, and that's something that we're doing. We're just making sure that the non-English speakers or our LEP population, that they can receive that service in a timely fashion. We're also developing a centralized source for the standardized signage and how we operate. So in the past, different departments did things differently. And so basically all of those assignments and differences have now been centralized to my division, which is my department, language services. So everything happens there. So now we are standardized across the system. And then again, just tracking community needs. And we're able to do this through the data we collect. Also, one of the things that we did internally was last year, I established a new language service council. So we meet every other month, and we do address the needs for the LEP patients and the families, because often when family members come with patients, a lot of times people or agencies, they don't realize, even health systems don't realize that the family members are also entitled to those free services. So if a family member requests an interpreter, then by law you are required to provide that free service to the family member as well as to the patient. And then we have increased our uses of our local vendors. And so currently we probably have about 5 local vendors that are pretty much all, I would say, minority-owned businesses or non-for-profit vendors that we use their services for inpatient services. So if we need a person to come in, they can use about the five different vendors that are local use. And we have seen an increase of in-person interpreters. We are looking to even add some full-time interpreters at Parkview. Once I get the job code created and posted, that job opening will be happening probably in the next few months. And then finally, one of the new things that we are working on, and this probably will go live specifically for one location, because that's where we're going to do the pilot, is we are now offering a new service, multi-language line. And that means that if a patient is a non-English speaker and they call in to the hospital, they will, if they call the standard number, they will be greeted in 9 different languages. And unfortunately, Burmese is not one of them. The vendor that we're working with right now is trying to get that set up, and this will be 24 hours that a patient can call in. We know that Arabic, Haitian Creole, because those are our top languages are Burmese, Spanish, Haitian Creole, and Arabic are the top languages that are used in Fort Wayne. Actually, the 5th largest service that we use are services for the deaf and the hard of hearing. And we're able to, even with our iPads, we're able to provide a sign language on the iPads. And we don't recommend using the phone because the cell phones are just, the windows are just too small. So you can't really see the sign properly. But that new service is rolling out, and we have some virtual care where a doctor, patient, and clinician can all speak to each other via through our ACHEC, which is a kind of patient. It's a patient. I don't know what we call that. That's the service we use for protecting us patients' information. But ACHEC is used by a lot of hospitals around the country, but we are moving to that. Now we do have telehealth, which is different. Like the doctor can call you on your cell phone, but this is if you're an inpatient in the hospital and you need to talk to a doctor. We can get the doctor, the interpreter, and the patient all in one group, just like a Zoom call, of course. And so we're working to roll that out as well. We should have that ready probably in the next month. And that's pretty much some of the things that are happening with language services right now. And as I get more changes and develop some new training tools, I'll let you know about it. Are there any questions?
Yes, we have one online. Go ahead.
Okay.
Hi, Dr. Diana. Thank you so much.
Hi.
This is Audrey. Thank you for that overview. That's amazing work that you all are doing. I wondered, you mentioned if you have over 7 employees, you need to be able to provide language services. Is this for like across, that's like the standard with the 1557 for any kind of healthcare provider, or how does that work?
I do believe so. And I think it's not, I think it's 15 employees, not 7. Let me check that number. I think it's 15. If you have more than 15 employees, then you're required to adopt that 1557 policy, the expanded policy. And you must have someone appointed as the 1557 coordinator.
Okay. And that's for any healthcare provider, like,
Yes. Yeah.
Okay. Good to know. Thank you.
Are there any more questions? There's something in the chat. Let me look at that. Oh, okay. So somebody, Colleen, thank you, Colleen, for posting that. Yeah. The training is, it is really in depth. It's covered so much. I can tell you there was 6-hour training, and we did it over a 3-month period. So, yeah, be informed.
All right. Well, thank
I
you
have
so
a question.
Oh, okay.
Okay.
Yeah.
I'll just so I'm with Neighborhood Health. So my question is more of a community impact type deal. So
Yes.
Obviously there's been a lot of reaction to the general public everywhere, including here. Kind of my question is along the lines of what do you think that looks like to the community? Because they're seeing what a lot of organizations are having to do to capitulate to these new standards. Kind of what do we say to them, or what should our message be to them about what this sort of thing looks like for them going forward?
Oh, well, We are still providing our services. We're still serving the community, right? And honestly, it's people first. We just put people first, and we just tell people, this is something that you need. We are providing that service. Now, internally, our, diversity, DE&I, our name change has occurred internally. So we are now belonging and health equity. So, which allows us to still continue to do the work, right? So the work's not changing. It's just wording has changed. And for people who are advocates and work in this field, they already know that we've been doing this work. This diversity is a name, right? What we do is action. It's a behavior, right? So you know how to do the right thing, and so nobody's you can't just because there are changes with it doesn't mean the service is going away, right? The language may change, but the service remains. And our goal at Parkview Health is provide excellent care every person every day, and we will continue to do that regardless of what names change, right? The service is still there. And I tell people not to be afraid, right? We know that there's people are afraid to come to the hospital, receive services. Interpreters are afraid to come in. But, they are still protected. Patients are protected at Parkview and treated with respect. With the exception, I would only say the exception of if we have a person who might be a felon and that has to do with law enforcement, then the policies are different for category, but in terms of everybody else, you are protected.
Can I ask one more light question? Because that kind of what you just ended on kind of led into some internal discussions we're having. How far do we go as far as what's the line exist for you for as far as advocacy and kind of letting things persist the way that they need to allow them to do their job?
What could you
So I mean, so like you said, people are scared to come in. So and
Yeah.
there's some people who may be actually in that gray area where there are like they may be felons or they may have actually reasoning why they should be approached by, I don't want to go like okay, like worst case scenario, like ICE comes, like we've had discussions as far as like how our staff should communicate if ICE were to come into our facility. Obviously that's the worst case scenario. So I'm just wondering what your opinion is on how far should we go as far as advocacy to our patients and respecting kind of the regulations.
It's a tough it is a tough question, and so we basically I work with compliance, right, and I work with our legal team, and we do have some processes in place in terms of advocacy. I think for every person it's different. Me, basically, I'm an immigrant, right, and so this is my life. Do I change? Right? No, I can't change. I just continue to do the work. And, sometimes you have to separate your work, your public life from your private life, right? And I have to be in compliance with what the organization tells me to do in terms of that role. But in my private life, I continue to do the work of advocacy.
Okay, thank you.
Good morning. I can't find my button to raise my hand, but if I could ask a question. So if somebody, so we have case managers, if they need to access language services through Parkview, is there a person or a department that they should reach out to help make that happen?
No, there isn't. So this is the thing, because I'm a one-woman department. In this world, DE&I doesn't go away, particularly the name changes. No, there isn't. We are hoping with the new multi-language line that is coming in, what will happen? So if a patient calls in, or let's say you call in and you need a service and you need an interpreter for a patient, right, that needs to make an appointment or needs to be directed to a certain office. The operator will answer that phone. It's almost like what do they call it? A I don't know what they call that, but the operator, you call the operator will, if the operator recognizes a language, will get the right interpreter on the phone with you. And so it will actually operate as like a three-way call. So the interpreter, once that interpreter is on the line, the interpreter stays with the patient or the person who is calling in until they are directed to that particular location or the office that they're trying to get to. The interpreter that is on the line will stay with that patient until everything has been completed, right? Whether they're setting appointments, whether they're going over information with the patient, the interpreter will stay on that line for as long as that patient needs them. And once they call in, our goal is to try to, because sometimes we have patients call in and, you know, if they don't speak English, then what do we do, right? And it's a runaround. By us having the multi-language line in place, right, it's kind of new for this area because nobody's really doing that. So, you know, we are piloting this out of Randalia because our greater use of non-English speakers is at Randalia. We see more there. And the top languages there, again, are, you know, the three that I mentioned. Strange enough, I was thinking that, you know, Arabic would be number 3, but it's not. It's sometimes it's 5, sometimes it's 4. But Haitian Creole is in the top 3 now as one of the highest numbers used and spoken in Fort Wayne. And we see these changes with the immigration, with the new immigrants moving into the community. Now, there's one thing that sometimes you know, I'll put my immigration hat on for just a moment, that a lot of times people, when they think about immigrants, they often classify them as either refugees or political asylums and so forth, migrant workers. Well, there's another group of immigrants that fall under different categories that are moving into this community, and they're not classified as you know, as refugees. And so the immigrant population is continually growing, right? I know, just talking to a good friend of mine who is the president of the Nigerian Association, we have over 5,000 Nigerian families in Fort Wayne. I didn't even know that, right? 5,000 Nigerian families in Fort Wayne. Some of them may not identify as that, but, you know, but they didn't come in as refugees, you know, the workers, you know, the physicians or whatever. So, you know, when we think about foreign nationals, you know, we have to move away from thinking about one classification, 1 or 2 classifications.
Thank
Well,
you.
thank you so much, Dr. Jackson. We appreciate the conversation. If you guys have any more questions for her, please follow in the chat or email. I'll be sending that out. We do have another presenter, so I want to give them enough space to share as well. So
yeah,
Dr. Craig, Dr. Hicks, I will come off mute and I will give you guys the screen.
Good morning. How are you all this morning? Thank you all for the opportunity to share. If you all see my screen well, it says hip study. Give me a thumbs up so I can be a shorter.
We've got your desktop showing, Dr. Hicks.
Stop sharing. There we go. Is that better?
Yep, that's better. Now we have the PowerPoint in front of your desktop.
Thank you. Thank you. How are we today? Thank you all for allowing us to be here today and to share about this hip study. My co-investigator with our Robert Wood Johnson Foundation supported study is Dr. David Craig. And I wanted to allow him an opportunity to wave and say hello. I want to introduce ourselves to you, and we as well have another co-investigator with us on this study, which is Dr. Elaine Hernandez. The three of us have been engaged in an effort since mid-2023 to once again look at the Healthy Indiana Plan. Dr. Craig and I were part of a study that was published in 2019, Health Equity, Urban Congregations, and HIP. So we are about 7 years in looking at Medicaid, and specifically the Healthy Indiana Plan in Indiana, where we've had an opportunity to interview in this second session, this second study, over 100 people around the state. We are looking forward to this discussion today that will allow us an opportunity to talk about HIP Medicaid, but also about some challenges at the State House specifically that are in place right now, and even some successes we've had most recently. But thank you all for allowing us to be here. I want to turn it over to Dr. David Craig now to talk about our study, and to then we'll move into a little bit more about Senate Bill number 2 and what's going on with Medicaid now.
Thank you, Dr. Hicks. It's nice to be here with people. We appreciate having been able to visit with this group previously, about a year ago, talking about where things stood at that time. Things have shifted dramatically since last spring to today in the Medicaid space. So this slide just emphasizes the importance of working with community. And the term community valued means not just working with community partners who are compensated for their expertise, but also trying to do work that's valued by the community. And there are different components: quantitative analysis. We've done 100 in-depth interviews in this study, including in Fort Wayne, working through our partner, Pastor Bill McGill, Amani Baptist Temple, who hosted us, as well as we really appreciate all the support from Health Visions Midwest in Fort Wayne. So thank you all very much for that. If you could move the slide forward. We have community partners across the state. These are some of our other locations, selected primarily where there are larger Black and Latino Hispanic populations on HIP. So trying to make sure that this work is grounded in the expertise and local knowledge of community, as Carlos emphasized just a moment ago. You can move forward. We welcome you to take this survey to help us understand what is happening in Fort Wayne in terms of support services, health equity issues. So please feel free to click on this QR code, and you'll have another opportunity later in this presentation to do that too. So our study very much built from this 2019 investigation we did, which was a very local study looking at 2 neighborhoods in Indianapolis, trying to understand how the Healthy Indiana Plan, HIP, as it existed before the pandemic, worked for people. And one of the things we knew at that time from state data, and very much was fleshed out by talking to HIP members, is that different racial ethnic groups experience the Healthy Indiana Plan differently. For some groups, the barriers that are built in, which include things like paying monthly premiums, for example, or co-payments, or more limited benefits, some groups experience these burdens as higher hurdles. And so that's what this slide indicates here, is that it may seem that everybody's crossing the same burden, same barriers, but sometimes the hurdles are higher for different groups. So if you could move this forward. This is from 28, well, no, don't go too fast. That little addition there was from 2018, and we can see that there was a disproportionate enrollment of African-American HIP members compared to white HIP members. Disproportionately, Black members were more likely to be on HIP Basic, which was a skinnier version of this plan with the higher hurdles than white recipients. One of the things that we've been able to show through the quantitative analysis is when you take away the barriers, guess what? People have more proportionate access to more generous benefits. But it isn't automatic. In fact, the state had to take administrative action more than a year into the pandemic to catch up Black enrollees to white enrollees. And so what this shows is that when the barriers are in place, different groups have different challenges crossing these barriers. And HIP is supposed to sort of work by choice and agency and responsibility, but the barriers prevent these very goals. So this is one of the things that we've tried to understand through this research. So now if you could move that forward. That's great. So this is a study, and there is a QR code to the full study, and we would really encourage you to take a look at this, share it through your networks. This is a case that we're trying to make given the current circumstances in Indiana, which is a supermajority on the Republican side. Now, Healthy Indiana Plan was created under the Daniels administration. It was expanded through Medicaid under the Pence administration, and the barriers were removed under the Holcomb administration. So this is an attempt to say this Healthy Indiana Plan has been an important support for many people. Let's keep it, let's build on it, let's strengthen it. And so we're trying to make the economic case for why it is good for Indiana in general. So here are some of the key messages that come through from this study. The Medicaid expansion is the #1 jobs creation program ever. This is a quote from a Harvard economist who has studied the Medicaid expansion across the country. One of the things that his work shows is in the states that expanded Medicaid, like Indiana, there are more jobs in healthcare because there's more support being given across the board to people who are accessing healthcare. Importantly, HIP strengthens the workforce. This is one of the primary complaints that you hear is that HIP supports able-bodied people who aren't working. This is simply not the case. 80%, based on studies of Medicaid expansion, are adults who are actively working, caregiving, or pursuing an education to work. So it's simply not the case. The rest of the next 10% are people who are disabled, even though they don't qualify for disability. So this is an important element. This is an important statistic to bring forward because one of the things that we're going to talk about are work reporting requirements that are being considered by the legislature right now. And then importantly, this is an important headline number. In fiscal year 2024, over 700,000 Hoosiers were covered by HIP at a cost of $667 per person for the year. If you know your health premiums, they are not $667 a year. Like, this is leveraging tremendous amount of healthcare for a very limited investment from Indiana. And importantly, that $667 is paid for by the tobacco tax and an assessment on hospitals. None of this money comes from the general fund. So one of the arguments that you're hearing right now in the legislature is there's a deficit in Medicaid in Indiana, but it is not here. Okay. So part of this proposal puts forward a call to action. We had HIP, and then it was HIP 2.0. Well, we're suggesting a new tagline, which is one HIP. HIP is currently a very complicated program with different tiers: HIP Basic, HIP Plus, HIP State Plan Plus, HIP State Plan Basic, HIP Maternity. Why not put everybody into the same category of full benefits with the maximum support and no cost sharing? Make it easier. Let's remove the program complexity. Let's make it easier to navigate. So the idea of one HIP is There's already been this record of innovation in Indiana built on wellness. Let's lean into that. Vision and dental care for all participants, simplified cost sharing for essential health services, and as a result, stronger relationships with primary care providers to enhance preventive care. If you know Pastor Bill McGill, he likes to coin the rhyme, and we want to quote him and give him the shout out. One hip ensures that no Hoosier's health will slip. We like that. And this is important because SB2, which Dr. Hicks is going to talk about, was going to be very threatening and still will be in important ways to people's ability to stay on HIP. So this is a graphic from the report. I'm not going to drill too deeply into it here, but you see that pie chart, which emphasizes how many people are working, caregiving, students, right? $5.4 billion brought in from the federal government, with a much smaller contribution from Indiana, 425,000 working Hoosiers who are on HIP as a result of this expansion. This is important, and there's another up to 700,000 people on HIP. So we need to celebrate what HIP has done, lean into this progress in terms of innovation and investment in wellness. It supports workers, hospitals, rural communities, and frankly, everybody. So one of the things we're trying to advocate is let's help the Healthy Indiana Plan live up to its name, for a healthier Indiana for everybody. But SB2 is a big challenge to that, and I'll turn it back to Dr. Hicks.
Thank you, Dr. Craig. So SB2 is a current piece of legislation that is floating right now. The two after Senate bill means that it, in the beginning of the session, was a priority. It's a bill that initially started out with a couple of caveats, a couple of caps in there that said that even though there are over 750,000 people that are currently on HIP, that it would reduce the number of people on HIP to 500,000. We still don't know what they had in terms of a formula for how they were going to kick people off. Dr. Craig has suggested that maybe they'll pick the people that were born on Tuesday and Thursday and kick them off. We don't know what they intended to do with that. The other heinous part of the original bill was that they were going to cap the amount of time you could be on HIP Medicaid to 36 months, which meant that you would have to either get sick quick or die. And so we are happy to report that last week on Tuesday, this bill moved over from the Senate to the House, and when it got to the House Public Health Committee, the first session, the beginning of the session, there were amendments that took out those two caps. So the 500,000 participant cap was taken off, the 36-month cap was taken off, and so that is a success. That success is not necessarily because of this flyer that has been changed just a little bit, but there have been certain iterations of not just this flyer, but our community leadership board has been engaged, and Hoosier Action from South Indiana, led by Tracy Hutchins Getz, who's also a member of our community leadership board. A part of our study has done a valiant effort to ensure that there was a cross-section of opposition to Senate Bill number 2. Even though these two caps have been taken off, there is still a work requirement that is a part of Senate Bill 2 as it has passed out of the Public Health Committee. It is now in Ways and Means, looking at the fiscal impact of what will take place. What you have heard us suggest in terms of one HIP decreases bureaucracy. What this does is it increases bureaucracy. It puts in effect a system that will require people to not just work, but you have to supervise and you have to check in to see how people are working, whether they're working or volunteering. There's no system in place for that, but certainly that would increase the bureaucracy. Not only that, but as a part of Senate Bill 2, there's an increased level of reporting. So as opposed to having to redetermine once a year, it is possible that it could be once a quarter. It's even possible that it could be once a month, that people would have to go in and find some way with more administrative burden to show that they were still below the income or that they were still eligible for HIP. These are things that are cumbersome that seek to keep people off of HIP Medicaid. We understand that this Senate bill is in tandem with what our governor put in place. There are limits on advertising, and the advertising is not just for MCEs. The way the wording in the bill still remains is that anybody that advertises. So if you stretch it, it could be health advocacy organizations. It could be pastors that stand up in churches. And we see how things are being enforced right now, even with ICE, as we talked about earlier today, that we don't know what this could look like in terms of enforcement for advertising. And so Senate Bill 2 continues to be a very dangerous bill. Yes, we can celebrate in green, let's go. Yes. But that is green because we still have to go. We still have to press. We still have to call our legislators. We have to call our representatives and let them know that we do not support Senate Bill number 2 because it is going to be more expensive to run. There's more bureaucracy that will be in place, and Hoosiers' health will be compromised. It's still a bill, as we said before, that will compromise rural hospitals and people in rural areas, probably even more so than urban areas. Those that are disabled will be bounced off of the plan. Those that we know there's a problem with infant and mom mortality. There's also the opportunity for just working Hoosiers to be kicked off. What we have created with our One HIP plan and plan that you'll have an opportunity, if you hit that QR code, to look at once again. This plan allows us to say that having people on Medicaid, having people healthy, allows us to have a more robust and productive workforce. So keeping people healthy and keeping people on this plan is actually a workforce builder. What they're seeking to do decreases workforce and also creates more bureaucracy, which is more expensive for the state of Indiana. We've created a financial impact plan, a positive impact plan that we hope will appeal to this supermajority in fiscal terms, even though we know that what they sought to do was to kill. We talked before about this governor's executive order. Understand that the second thing that this governor did, Governor Braun, when he got into office, after he dismantled DEI, the second thing he said was that we are going to sign an executive order that says that you have to stop advertising for Medicaid. And so they're in tandem with one another in that regard. We need to continue to keep on fighting so that we have more people that have an opportunity to be healthy in the state of Indiana. We need to keep the Healthy Indiana plan, which has zero impact, as Dr. Craig has said before, on the general fund of the state of Indiana, even though the state of Indiana still operates with a super surplus. But this plan, 90% of the money comes from the federal government. The other 10% that keeps people healthy comes from a hospital excise tax and a cigarette tax. So 100% of this plan is taken care of so that people can stay healthy. And so we understand what the meta or the MAGA narrative. Yes, that is in play right now. But we encourage you to continue to be the advocates that you are and to reach out to representatives and encourage others to look at this and to reach out. We have been intentional about forming a community leadership board in these 5 cities and even beyond that. That is one that is not just bald-headed black guys from Indianapolis, Indiana, like me, but we have a cross-section of people from rural and urban, suburban. We have people from the Latin community. All communities are represented as we provide this opposition and resistance to that which is taking place. We're appreciative that you have taken time with us on today and allowed us to come. And we wanted to go very speedily through our presentation so we'd have an opportunity for questions at the end. And so we are there. Dr. Craig, if there's something else you'd like to say to wrap us up, if not, we'll take questions.
I guess I'll just amplify the message I just put in the chat, which is Representative Martin Carbaugh, who's a Fort Wayne representative, is on the Public Health Committee. There was a call to sort of reach out to him and others, and I appreciate everybody who did that prior to Tuesday's session hearing. There clearly was a shift in the room, and people reaching out and making voices heard is crucially important, and that continues.
Resistance, resistance, resistance.
So where do you think this bill is going to go? What do you think is going to happen?
Unfortunately, we are moving to Ways and Means. If it gets through Ways and Means, right now as it goes there, there's the threat of litigation that will come. There are other jurisdictions, other states that have provided resistance through litigation for the work requirement. And so there's the possibility for that. And so right now, as it goes to Ways and Means, that's one of the narratives that we take, that there's certain litigation that's going to come if you keep this work requirement in there that requires, the way it's written right now, children would have to work or volunteer. Right. Yeah, I mean, it's poorly written, and doesn't make a whole bunch of sense, but that work requirement is still in there. More than likely with the supermajority, it may be changed, it may be altered, but it once again is Senate Bill 2. It's a priority for the senators, and so more than likely it will pass, and then this governor certainly will sign on and will not veto, because he's coming up with various different ways to reduce the numbers of people on Medicaid, even though we feel that would kill people. And so I think that's what will take place, even though there'll be some litigation will come afterwards. But right now, we need to once again resist. We need to make sure we are calling our representatives and letting them know that we don't agree with this and that it just needs to go away.
I work for Tobacco Free Allen County, and one of the things that we're trying to help make happen is to increase the cigarette tax by $2. And so I would like to put a plug in for you all to advocate for that as well.
All right. Are there any more questions in the room or online?
Kat, can you hear me?
Yes, we can, Sharon.
Okay, I'm sorry. I had a very quick question about the research that found that African Americans were on basic HIP as opposed to the, HIP plus. And I wonder why that was. It wasn't because they were choosing that for some reason, or were they being guided toward that option? Do you know what made those findings the way that they were?
That's a great question, Sharon. Thank you for asking. It's neither the case that people were choosing basic or being guided to basic. So the way that HIP is constituted is I apply for HIP, I'm eligible, my application is approved, and I default onto HIP plus. Everybody starts on HIP plus. The only way to end up on HIP basic is you miss 2 consecutive months of what are called power account payments. And power account payments are these monthly premiums that HIP members had to pay that range from $1 if your income is basically zero, up to as much as $20 a month if your income ranged up to 130% of the federal poverty level, which means nothing to people, but that's about $20,000 a year. So that the only way to get on basic was to not cross a barrier, was to not navigate that monthly premium. And then you would be dropped down to basic. And the thing with basic is once you're on basic, your vision coverage goes away, your dental coverage goes away. And instead of that $1 a month that you're being asked to pay, now every time you go to the doctor, each prescription you go to fill, there's a copay. $4, right? $4 copay is a huge barrier when you have no income. You have 5 monthly prescriptions, that's $20 a month, right? This is beyond the reach budgetarily for the people who are on HIP. And so this is why the one HIP proposal would eliminate basic and would also eliminate those monthly power account contributions.
So basic is the punitive plan, and how that plays out in real time is that somebody would get a notice if they still live at that address. If they do get the notice, they have 13 days to respond. If they don't respond, then they are kicked down to HIP basic. If you do respond, then what it can wind up being is that you have to figure out a way to get a $1 money order or a $1 check, or put a $1 bill in an envelope and put a stamp on that envelope, and in 13 days have that come back. It's a system that is set up for failure, and is a part of the administrative burdens that Dr. Craig and I have been voicing and resisting through our now second study and down through these years.
And one thing to layer on there too, the way the program operated, it was possible for nonprofit organizations or other individuals to pay people's power account contributions for the full year, which was helpful. And this happened to a significant degree. But with all of these income reviews that are happening in back offices behind the scenes, if your income went up, let's say you're a seasonal worker, suddenly, instead of your $1 a month payment, your payment goes up to $5. And that year of payments is exhausted very quickly. This is the problem with these frequent income reviews. And the research shows that frequent income reviews affect the poorest people the most, and people who are Black or Hispanic the most. And so this is the real problem with this, these income reviews that are being mandated if data comes across the state desk that any changes have happened. And it's important to say this is, in SB2, this isn't just for the HIP population, this is for everybody on Medicaid. This is the 2 million people on Medicaid who would be subjected to these more frequent back office reviews. There was a conversation with one of the Republican reps after the meeting who was saying he was considering an amendment where you would have to sort of be flagged after 2 quarterly income reviews before you lost your coverage, which is not great. But it's something. So maybe there's some awareness of the problems, the churn, the administrative burden, the hazing that just goes on with these income reviews.
Where's the intelligence on all this? I mean, is there anything I was just trying to figure out, with all the scholars that we have and all the experience, where is the intelligence? Is there any such thing as intelligence anymore? Does it exist? I don't hear anything that really makes any sense. So I don't know how you're going to work on something that makes no sense.
Yeah, that is the problem, that what we're seeing coming down from Washington and what we see taking place right now does not make sense. And so even in advocacy communities, my suggestion is that when things don't make sense, then, maybe we need to come at this in a crazy way. Maybe we need to not make sense as we fight as best we can, because it doesn't, and don't seek to try to deal with it in a sensible way, understand it doesn't make sense.
Now you talking.
Yeah. And so I think what we have done is to create the economic is what we've done is to create an economic statement that hopefully does make sense, that says that by decreasing this bureaucratic hazing and by bolstering the workforce, what makes sense is for more people to be on HIP and to be on Medicaid and to have a healthier community. And that's what does make sense. So we have some stuff that makes sense, but there's also, something within me as the advocate that says there's 7 other ways we need to fight this. And, some might be from left field and we're going to throw haymakers as we've done so that there's good cop and bad cop going on. There has to be a Malcolm and a Martin and a SNCC and a Panthers and all of that.
I have a question. As you were collecting this data over a time frame, what was the time? Well, 2 questions. What was the time frame like? And was there information on language barriers? And how did you collect the information with people that have disabilities, blind, or hard of hearing, and other disabilities? I mean, potentially these numbers that you're looking at that you presented are significantly higher, because I have to believe that so many people were missed. And so, yeah, what did that look like? Was that information included then as you were doing this this data, not data collection, but doing the research?
I can take a first shot at this. No, that's an excellent question. The quantitative data analysis is based on statewide data. So that really is a comprehensive data set for everybody who's been on the Healthy Indiana plan, including people who are likely to be disconnected, right, or might have disabilities that impair participation. We did 100 in-depth interviews around the state, but that sample is going to highlight more people who are connected, right? People who respond to appeals, people who have the technology. So we are looking to try to phase into another data collection moment, which is designed to be a bit more to reach populations who are harder to reach. And this will actually be our second go of that. We know that this is important to work through trusted community partners because who wants to talk to a group of outsiders or at least share in depth? So this is one of the reasons why the Community Leadership Board is so essential, to kind of build those relationships and try to extend that trust. So we are about to embark on another kind of data collection attempt, which will not fully rectify, but hopefully will give us some kind of comparative basis to ask a great question.
Yeah, a qualitative might be helpful too, and through maybe, you mentioned the community-based partnerships, maybe having like small meetings at different locations. I know we do the community health assessment, and so we look at different groups, and it's all qualitative, so they're meeting in person and gathering information. It would seem that might be a way to get some more data, maybe looking at different communities, both in the rural areas and the larger communities as well as the cities. It seemed like you would get some more information, because I do believe that the qualitative tells the story. I know it's a lot of work, but it does tell the story. And sometimes the quantitative is just numbers and people don't really hear that. But you've broken it down for us. But when you hear the real stories, then it really would make a difference.
Absolutely. We have done Zoom and in-person sessions in each of our cities, but all in urban areas. And Sawubona, we hear you, that there's the need for us to get to those that are disabled, those that are in other demographic categories. And as Dr. Craig has said, where we're moving now is to look at those that don't have an access or low access to technology, so that we have an opportunity to hear voice and to understand from those that might be a little bit more transient than our initial sample indicates. So we're still working, and it's an action-oriented study, and so we sort of do in season and out of season. We're in season right now with that which is taking place at the State House, and as the session winds up, we'll be back in the field again, wrapping up these secondary interviews, so that we'll have an opportunity to, once again, as we did in 2019, make clear recommendations for changes that seek to annex those that have been disenfranchised from healthcare and health coverage in our state.
And your point about stories is so important. The 2019 study that we did opens with 4 stories. And there are a lot of stories. With more time, we could tell today.
Yeah.
So I appreciate you're making the point that really it is stories that matter, because partly it's pushing back against stories. And the stories that it's pushing back against are, people get the health care they deserve. And this is a big story that's out there that needs to be taken on.
Yes.
I'd just like to say thank you for the work that you're doing. It's so important. The agency I work for, our client base are HIV positive or AIDS or hepatitis. The majority of our clients are on HIP, or we're trying to keep them on HIP. So I know firsthand some of the things you're talking about. So thank you for the work that you're doing at that upper level. It's really, really appreciated.
Yes, and I want to echo that. Thank you, Dr. Hicks and Dr. Craig, for joining us today and sharing this vital information. And again, if you guys have any more questions or concerns with regard to them, please, I'll drop their information in the email and you guys can reach out to them. And then Colleen has included a lot of resources to be able to directly connect to some of those senators, which I'll also share with you guys if we already don't have it available. And I want to spend some time now to kind of share some announcements from Health Visions, and then you guys in the room or online. And so next month, we have a few things going on from Health Vision. So we have our Thriving Thursdays on April 10th and April 24th. Those classes are led by myself or Miss Peggy. And this next month, we'll be talking about taking care of the kidneys and preventative stroke. And the week in between those 2 classes, myself and my coworker from Hammond, our Hammond location, will be traveling to Indianapolis and having a conversation with 2 doctors there, Dr. Joanne Matori and Dr. Dunji Poitras. And we'll be talking about infant mortality, maternal mortality, and continuing this conversation around the need to shift the gear on there, because it's still happening. Babies are still dying before their first birthday. Mothers are still dying in the birthing process. And so we hope to give some more resources and tools that you could be taking to the doctors to get this needle changed. And now we want to hear from you all. If there's anything going on in your sectors, what's happening, please let us know now. Anybody in the room?
Contact your legislators. We need to get that cigarette tax up to $2 a pack.
Right on. Contact the legislators.
If I can put a plug out there, we have an open position for a bilingual English-Spanish speaking Hispanic community liaison that would do education prevention outwork for our organization. So if anybody knows of anybody who might be interested, we would love to be able to get that position filled. Thanks.
I have a quick announcement. Thank you, Dr. Craig and Dr. Hicks. This is very, very informative. I am currently working with Miss Carla Harrison, a part of the Health Equity Council, and I'm offering free training for looking at communities of color, the impact of COVID in the communities of color. Of course, we had to take the word color out. So looking at looking at the impact of COVID in communities. And the training is free. We have until, I believe it's July 1st to get this all done. So if anybody is interested in getting the training, it's free. Please reach out to me. We can do it virtually. I can come to your location, send me an email, and I will come and do the training. Thanks.
All right, so this is June 30th. And then another thing happening on April 10th is the Save the Date for the State of the Nation Town Hall happening at Come As You Are Community Church. And that is going on at 6 p.m. to 8 p.m. If there is no other announcements, I want to take this moment to, oh, yes.
Throw one out there?
Yes, please.
Cancer Services of Northeast Indiana just last month launched a Spanish speakers support group. So anyone who is navigating cancer or has in the past or is living with cancer as a form of chronic illness, which we're seeing a lot more of, we do have a Spanish speakers support group available for them. It's based in our Warsaw location, but it is available virtually as well. So it is accessible to anyone, even if they're not, local to the Warsaw area. And that meets every second Tuesday from 3 o'clock to 4:30.
Awesome.
Could I ask, when you send out the contact information, could we get the link that he was posting with the QR code for contacting the legislators? I tried, but I couldn't get it.
Yes,
on
yes,
the
I
screen.
scanned them both, so I'll be sure to include that as
perfect.
well, yes,
Thank
oh yeah,
you.
no problem. All right, if there was no other announcements, those of you who have not already renewed your membership, please, please, please do so. This is our last open meeting. We will be allowing any new organization who has not joined before, ever been to a meeting, to still join in and kind of get a feel for the meeting. But other than that, we will just be inviting members, and then affiliates will get the recorded version after. And so we thank you guys. We're going to end it online. Those of you in the room, feel free to continue to connect. Thank you again. We'll see you next month in April.
Thank you, everybody.
Yes.